Well, thank you very much. Incredible words. So Dr. Sharma just went over a beautiful overview on where we stand with transcatheter, and I think we're all eager to hear what the rest of the day is going to bring us. I was asked to actually talk from a clinical perspective on where we stand with valvular heart disease in 2019 and going into 2020. So what I thought I would do, I would kind of start out with what we did, what we are doing, and then go to what we need to do, but talk to you not as an interventional cardiologist, but from the perspective of a plain old clinical cardiologist, because we're the ones that need to be able to know when to refer these patients to all of you. We're going to mainly talk about aortic stenosis because there's been this incredible journey with aortic stenosis throughout the decades. And what I wanted to do was start to say that aortic stenosis is a prime example on where we are continually changing our mind about how to treat these patients as the benefit of our interventions starts to outweigh the risk. So if you think about when aortic stenosis was first intervened upon in the 1960s, basically all that we had was our physical examination with the late systolic murmur, and we had the catheter traces with the pullback pressures. And at that time, the definition of severe aortic stenosis was dependent upon who was writing the paper. So you could have gradings of 50, gradings of 40, valve area 1, valve area 0.7, valve area 0.5 centimeters squared per meter squared. We also knew that once you became symptomatic with severe aortic stenosis, your prognosis was much worse, but this was based on clinical findings, not necessarily numbers. At the time the initial valves were put in, the operative risk, especially at places like the NIH, was 8 to 10% with these type of valves that if you look at the 10 to 15-year outcome of these old ball cage valves, 50% of patients would have embolic events, and the tissue valves would nearly all degenerate over 10 years. So at that time, and this was the teaching back when we were many of us were fellows, the only indication for aortic valve replacement was symptoms and severe stenosis. Now, let's not go to where we are now and what we are doing. And I think what we've learned from the natural history studies, such as this one from Patty Pellica, is that if you take a patient with severe aortic stenosis who's asymptomatic and you follow them out, at 5 years, 3 out of 4 of them are either going to die or go into heart failure and need something done. So we know it's not benign even if they're asymptomatic, and now our surgeons are able to operate on these patients with a less than 1% risk. The valve prostheses are much better. Embolic events and bleeding is less than 1% of year. The tissue valves has a much longer longevity. So with a lower risk aortic valve surgery and better outcomes, we feel that we need further risk stratification. Now, Dr. Sharma already showed this, but I think it's very important as we look at the patients to be able to categorize them in the stages. And we took this from Clyde Yancey's heart failure guidelines, in which he put patients in the stages, and lo and behold, it was very, very helpful in how we look at patients who come into our office. Now, we were then able to look at natural history studies, and based on the natural history studies, actually come up with an evidence-based definition of severe, which was based on outcome studies when the outcomes started to deteriorate. So that's where we got the gradient of greater than 40 millimeters of mercury, velocity greater than 4 meters per second, or valve area less than 1 centimeter squared as the definition of severe. Now, we then said, well, let's take these patients who have severe disease and further categorize the asymptomatic patient into those patients whose left ventricle remains compensated and the left ventricle is decompensated. And the definition of decompensated left ventricular function, because of the long-standing pressure overload, is when either the outcome is reduced or left ventricular function post-operatively is reduced, and because of that, we were able to come up with, at least a couple years ago, a definition of an ejection fraction of 50%. Now, stage D then are patients who then become symptomatic, and we also recognize that not only do we have patients with high gradient, but we have patients with low gradient, low EF, and low gradient preserved EF. So those categories were all put into place. But if we think about what we do with the patient coming to our office now, and this is where we have to thank Clyde, A and B are at risk in progressive disease we're going to observe. Of course, the patients who are symptomatic, we're going to intervene. For those who are asymptomatic but have gotten to the point where the disease is severe, for C2, when the left ventricle is decompensated, we're going to intervene. And then the question arises, well, what are we going to do with those patients who have already developed the hemodynamic consequence of severe disease but remain asymptomatic? So these are the patients that we go into further risk stratification. And by risk stratification, I mean this, is that data has shown that treadmill testing can further risk stratify, and those patients who are able to go less than 70% on their treadmill, who drop their blood pressure on the treadmill, are going to do poorer. We've also found out that you have further risk stratification by disease severity, in that the higher the velocity, the poorer the outcome. So the last set of guidelines that we had was the indications for surgical aortic valve replacement would be all patients who have any symptoms, any drop in ejection fraction, but the asymptomatic patients who can have intervention at low risk, it would certainly be reasonable to operate on them who have a positive treadmill or very severe aortic stenosis. And then, of course, came the transformation that all of you here have enjoyed, and that's the transcatheter. I think all of us, when we saw the very first one going in at our institution, just said, wow, you know, boom, all of a sudden, severe critical aortic stenosis becomes no aortic stenosis whatsoever. So, of course, with the people in the room here, the randomized trials have come out, and we found out that not only was TAVR better in inoperative patients versus medical therapy, but high-risk patients versus SAVR, and now we've got the intermediate, and as Dr. Sharma said, the low-risk patients are comparable, maybe even better. So these are the 2014 guidelines, where at that time we said SAVR should be used, and low intermediate TAVR is really only in the inoperable and kind of a patient choice as to whether or not you should do in the high risk patients. Then came the 2017 guidelines, where of course we went down to the intermediate risk patients of SAVR versus TAVR. We're not supposed to say what's going to come out in the new guidelines, but I think everybody believes now that, boy, anybody with low, intermediate, or high-risk aortic stenosis should have the chance of receiving a TAVR, and the decision will not necessarily be based on risk, but should be based on anatomy. So it should be based upon whether or not it can safely be done, what is the incidence of the paravalvular leak, and then also we have to take into consideration the patient and valve longevity, which we are waiting for to determine the ultimate role. Now, that's what we are doing. We now have better and better interventions, there's no doubt about it. But we all understand that if we still only intervene according to the guidelines as written in 2017, there are patients who are going to die following AVR. We've seen that in our longitudinal studies. And despite the fact that we're relieving the pressure overload on the ventricle, persistent heart failure is still going to occur in a number of patients. That's because if you think about the underlying pathophysiology of what's happening with these patients with aortic stenosis, that long-standing pressure overload goes to compensatory hypertrophy, which normalizes wall stress, but that in itself causes a myocardial oxygen demand mismatch. There's myocardial ischemia, and eventually that's going to cause fibrosis and scarring in the ventricle. So If we think about it, by the time we operate now, if we would only go by what's in the guidelines, the left ventricle is already damaged. And there's some beautiful MRI studies that have shown that if we start to look at the degree of scarring and fibrosis in the ventricle by gadolinium enhancement defects, as we wait for our, quote, guidelines to operate on a patient, they're already going to develop diffuse fibrosis, and by the time we operate, they're going to have developed replacement fibrosis. And we also know that if they operate at the time that they've already developed this interstitial replacement fibrosis, the mortality after operation is going to be significantly enhanced. So we're operating too late. Now, what else do we know? What else have we found out in the past year or 2 or 3 years in terms of operation and intervention for aortic stenosis? Now remember, we had defined severe aortic stenosis as a velocity greater than 4 meters per second, mean gradient greater than 40, and a valve area less than 1 centimeter squared based on the early studies. But as we look at the studies that have been coming out in just the past year, this peak velocity of 4 meters per second is probably outdated. And as we take a look at even what we define now as moderate aortic stenosis, the outcome of moderate aortic stenosis, if left untreated, is actually similar to that of severe aortic stenosis. So we're starting to question as to whether or not our, quote, cutoffs of 4 meters per second, 40 millimeters of mercury, are actually accurate, and should we in the future start looking at lower and lower thresholds for the definition of severe? And then remember, I talked about the ability in the asymptomatic patient to determine whether or not the left ventricle is compensated or decompensated. And we had initially said the ejection fraction of 50% or less is decompensated. But the data that we have now shows that even if your ejection fraction is less than 60%, so let's say it's 55, 58%, that still means that the pressure overload is overcoming the response of the left ventricle. And if we left that untreated, the prognosis would be poor. We have other parameters such as stroke volume index, diastolic function parameters, myocardial strain, Doppler tissue imaging. We have other factors such as BNP, such as some of the biochemical factors. We've got other clinical parameters that are important, body mass, nutrition, gait speed, so on and so forth. So up until now, we've used ejection fraction, symptoms, and valve area to time aortic valve replacement. But our current data is telling us we have to look at diastolic function, stroke volume index, things like torsion, twist, strain, biomarkers, gadolinium enhancement defects, and we know in the near future we're going to have more and more and more parameters. So this is actually the future of medicine, and the people at Mount Sinai have actually done this with aortic stenosis. Partho and his group have shown that you use machine learning to take every single piece of information that you have about this patient and provide a precise phenotypic risk assessment for the individual patient. And this is Partho's initial study where he just took everything in an echocardiogram, put it all into a machine, looked at the outcome, and had the machine actually predict who's going to do poorly and who's not going to do poorly, and that machine prediction is much better than anything that we as humans could do. So a general perspective on aortic stenosis, I think what we have now is we truly have better and better interventions. The outcomes are better. The valves are better. The risk of an intervention, particularly with TAVR, is lower. We need lower and lower thresholds. We need to identify the higher risk patients in order to prevent the adverse consequences of pressure overload. And in the future, and I don't think it's too far off, we're not going to need guidelines to say this gradient, this ejection fraction, so on and so forth. we're going to throw everything about the patient into a computer, and they're going to give us a precise, individualized risk assessment that we can then weigh against the risks and benefits of intervention. And that's going to be the future, and that's going to come up in the next 4 to 5 years. Now, I just kind of gave an overall clinical perspective on aortic stenosis. I just talked with Michael here now. We've got to do the same for other diseases. In mitral regurgitation, in primary mitral regurgitation, there is no doubt that we are continuing to operate too late after the onset of irreversible left ventricular dysfunction. Even if we are sending our asymptomatic patients to valve operation, there's only a few surgeons around the country who can reliably do a valve repair with a greater than 95% chance of success. So there's a large number of patients around the country who have severe primary mitral regurgitation, and we're just waiting on. And as we wait, the left ventricle gets bigger and bigger. It develops irreversible left ventricular dysfunction, and the patients are ultimately going to do poorer. We're going to need lower risk interventions. We're going to need more effective, durable interventions. And as we have that, we're going to intervene lower and earlier and earlier and earlier. And I would suspect that in the next 5 to 10 years, if your group here comes up with these catheter-based therapies, we're going to be intervening on moderate mitral regurgitation before it gets out of hand. Secondary mitral regurgitation. We've had a dramatic change in our thinking on secondary mitral regurgitation due to what's happened from the catheter people. We always thought this was a disease of the left ventricle, but based on the COAPT trial, we're actually finding out that correcting the mitral regurgitation itself may be beneficial. We never thought that that would be the case. Steve Bowling was the only surgeon who thought that was, and his own people said, well, you're not going to improve mortality. So as cardiologists treating valve disease, we would always ignore the mitral regurgitation, but now we're finding out that by correcting it, it may be beneficial. Now, we do have the difference between the MITRA-FR trial and the COAPT trial, so we need to determine who will benefit, who actually has more LV, who has more mitral regurgitation, but that will come with time. And then finally, the patient with the tricuspid regurgitation is a huge growing problem. As cardiologists, we're seeing an increasing number of patients who come in with severe right heart failure, and it's not due to intrinsic tricuspid valve disease, it's due to device leads, and there's an atrial fibrillation tricuspid regurgitation that is occurring in our patients, particularly those with HFpEF, that we're seeing more and more and more on. And in the past, we've always been reluctant to intervene on tricuspid regurgitation because the operative risk was thought to be 8 to 20%. But now we've got surgeons who can do this with 2 to 3% risk. And as we have alternative approaches with your catheter-based therapy, by gosh, this group of patients themselves are going to be able to benefit from earlier intervention. So from the perspective of a plain old clinical cardiologist, I just wanted to present a little overview on what we did, what we are doing, and what we are doing certainly is antiquated in my mind, and then a little look into the future about what we need to do. Thank you very much for your attention.